morning, good evening, good afternoon, all depending upon where you're joining us from. Welcome you all to the session 3 or week 3 of solving case studies for your medical coding exam group study. So, how are you all doing? Yes, I'm doing good. I can see that hello from Tampa. Yes, hello. So welcome back everyone after week 2. We had a great session in week 2 and I did review everyone's feedback. Thank you for your feedback and letting us know that the class helped you. So now we are back with the week 3 and I don't want to waste any time and let's get started. So how do we solve a case study for the board exam? We use few steps here at AMCI. One of the steps is to select the code that best matches our inventory, right? Yes. So how to solve a multiple choice case study scenario for the board exam? So here at AMCI, we use these steps. We use yellow to highlight the diagnosis, green to highlight the procedures, and pink to highlight the inclusive procedures. Step 2, document your inventory and diagnosis and select the primary. So that is a very important step. Step 3, review your guidelines. Step 4, select the code that best matches your inventory. Also, notice when highlighting to not highlight the following: the things that are observed by the physician, the closures such as sutures, cables, etc., the hemostasis, which is bleed control, the drains, the irrigation of the surgical site, installation and removal of the clamp, the dressing, and finally the surgical risk. So how do I sound, coders? Are you able to hear me? Is it audible and clear? Please do let me know. Great. Thank you for letting me know. So let's move on. So we have Mrs. J, our AMCA Curriculum Director, and that's me, Sandeep, your instructor for the Tuesday night group studies. And goals for the presentation. So we also, goals for the presentation. We also have Miss Katoya, I hide the slide. Okay. So we also have Miss Katoya, who's joining us, and she is going to help me with the chat. She will be interacting with you in the chat, and she is also going to help me in creating the scenarios as well. So welcome, Miss Katoya, as well. And goals for the presentation for this week: we are going to review the female genitourinary system scenarios. We are going to review nervous system scenarios. Finally, we are also going to review the anesthesia scenarios as well. So there are a lot of things which we have to cover here, and I can assure you that we do have great scenarios as well. Okay, so are you ready, coders, to review the female genitourinary system? Yes, great. That's the spirit. Awesome. Okay, so we have case scenario number 1. So let me ask Miss Katoya, are you ready to read the scenario for us?
Yes, I can read it.
Thank you, Miss Katoya. The stage is all yours.
Okay, what are the CPT and ICD-10 CM codes reported? A, 58671, modifier 50, Z30.2. B, 58600, Z30.2. C, 58615, Z30.2. And D, 58671, Z30.2. Anesthesia general with LMA, preoperative diagnosis, patient requesting sterilization, postoperative diagnosis, sterilization. Procedure performed, tubal ligation with bilateral Falping ring application. count, needle sponge, and instrument counts were correct. Intraoperative medications, 0.25% Marcaine with epinephrine. Operative findings, the left ovary was mildly adhered to the side of the uterus. The right ovary appeared normal. Both tubes appeared normal. The upper abdomen appeared normal. There was a small subserosal fibroid approximately 1 to 1.5 centimeters on the left upper aspect of the uterus. Description of procedure. After informed consent, Mrs. Matthews was taken to operating suite number 4 and a general anesthesia was administered. She was placed in the dorsal lithotomy position. She was sterilely prepped and draped in the usual manner. A sponge stick was placed vaginally. An infraumbilical incision was made and a non-bladed trocar and sheath were placed. Proper placement was confirmed, and insufflation was performed. A suprapubic incision was then made, and the suprapubic trocar and sheath were placed under direct visualization. Findings were made as noted above, and the right tube was ligated with the fallopian, and then the left. Pictures were taken to document proper placement. All instruments were removed and gas was allowed to escape. The sheaths were removed. Marcaine with epinephrine was placed again at the incision sites, and they were closed with monocryl in a subcuticular manner. The patient was allowed to emerge from the anesthesia and was transferred to the post-anesthesia care unit in stable condition. Coders, you have, I think, 2 minutes to solve.
Okay, coders, that is time. And okay, so let us solve this question. The correct answer to the scenario is going to be option D, and we have post-operative diagnosis, which is sterilization, tubal ligation with bilateral fallopian ring application. That is a procedure being performed. Patient was given general anesthesia and was placed in dorsal lithotomy position. Infraumbilical incision was made. Suprapubic incision was also made. The right tube was first ligated with fallopian ring and followed by the left. All instruments were removed. So these are our procedure inventory. We have tubal ligation with bilateral fallopian ring application performed, and the diagnosis inventory is sterilization. Let me show what procedure was performed here. So as you saw or as you read in the scenario, there were two incisions was made. One is an intraumbilical incision. Over here, one is a suprapubic incision, and bladed as well as non-bladed trocars were used. So what is a trocar? Trocar is actually a instrument that is used during a laparoscopic procedure and other minimal invasive surgery, and this is used to make small puncture-like incision in the outer layers. So these incisions allow the surgeon to insert cannula through which surgical instruments can be introduced. So that is the purpose of a trocar, and it is a key word in this scenario, and the use of trocar is an indication that this procedure is a laparoscopic surgery. Okay, yes, great. So we have a tubal ligation that is performed. It can be done using several other techniques such as electrocoagulation, by clipping method, by using a band as well. So in our procedure, tubal ligation was achieved with the help of a fallopian ring application. So this is another image that shows how a tubal ligation can be achieved with the help of a fallopian ring. So this is how it is done. Now let's come back to the coding portion. So we have option C, which is 58615, and that is coding for an occlusion of fallopian tube by device such as band, fallopian, vaginal, or suprapubic approach. And we have to look into the approach used in this technique. As I said, we have a laparoscopic surgery performed and not using a vaginal or suprapubic approach. So that means option C is incorrect. And option B, which is also coding for a ligation or transection of fallopian tubes, abdominal or vaginal approach. So again, approach is wrong in option B as well, which will eliminate option B. Now we have option A and D to choose from. So both option A and D are having same CPT code. So let's review the code language of CPT 58671, which is coding for a laparoscopy surgical with occlusion of oviducts by device such as band and band clip or fallopian ring. So yes, this is a good language, good code selection. And now between option A and option D, the only difference is that option A is having a 50 modifier. So a 50 modifier is used to indicate that a bilateral procedure has been performed. But if you carefully read the scenario, you can see this is a laparoscopic surgical. Sorry, if you read the code language, you can see that this is a laparoscopic surgical procedure with occlusion of oviducts by a device. So oviducts means more than one. So if the code language itself is saying that this is a bilateral procedure, or this can be coded for a bilateral procedure, then we don't have to append a separate 50 modifier, right? Is it clear, coders? So that means option A is also incorrect. There is no need to append a 50 modifier because the code language itself is stating that this is a bilateral procedure, and that would eliminate option A, and the correct answer is going to be option D, 58671 Z30.2. So how are you doing, coders? How are you feeling? Please let me know. Please let me know in the chat. Did the explanation help? Good, great, great, great. Okay, great. Okay, so let's move on to the case numbers, case scenario 2. Miss Cutter, please, and thank you if you can read the scenario.
Sure. What are the CPT and ICD-10 CM codes reported? A, 59841 C33.2 035.NXX0. B, 59855 Z33.2 035.9XX0. C, 59840 Z33.2 035.9XX0. And D, 59856 Z33.2 035.9XX0. Diagnosis: intrauterine pregnancy at 18 weeks with multiple fetal anomalies. Procedure D&E: anesthesia, moderate sedation. Indications: the patient is a 29-year-old gravida 1 at 18 weeks with multiple fetal anomalies who desires a termination of pregnancy. Description of procedure: the patient was brought to the operating room and moderate sedation was administered by the anesthesia team. The patient then placed in dorsal lithotomy position and was prepped and draped in usual sterile fashion. The laminara and prostaglandin suppositories were removed. The patient's cervix was dilated to 5 to 6 centimeters. There was a bulging bag that ruptured during vaginal prep. A speculum was attempted to be placed, but the fetus was already delivering into the vagina. The umbilical cord was severed at this time, and no fetal heartbeat was noted on ultrasound. Ultrasound guidance was used for the entire procedure. Gentle traction was applied, and the fetus delivered intact. There was no respiratory or cardiac effort noted. Beer forceps were then used to remove the placenta intact. There was a small amount of bleeding noted from the lower uterine segment. 20 units of Pitocin was added to the patient's IV fluids, and pressure was held against lower uterine segment for 5 minutes. At this time, hemostasis was noted to be excellent. The speculum was then removed and the patient was taken out of the dorsal lithotomy position after her perineum was cleansed. The patient's anesthesia was discontinued and she was brought to the recovery room in stable condition. There were no complications during the procedure. The patient tolerated the procedure well. Specimens, the products of conception, were sent to pathology for cytogenetics and pathologic evaluation. Plan: the patient will follow up in the outpatient clinic. You have 2 minutes to solve. Good luck.
Okay, coders. Thank you, Mr. Toya, for reading that scenario. Great answers in the chat. I was just looking at your responses. Good try, great answers. So let me walk you through this scenario. We have intrauterine pregnancy at 18 weeks with multiple fetal anomalies. Procedure performed is D and E, which is a dilation and evacuation. Moderate sedation was given to the patient. Laminaria and prostaglandin suppositories were removed. Patient cervix was dilated. Speculum was attempted, but fetus has already delivering into the vagina. Ultrasound guidance was used for the entire procedure. Speculum was removed as well. The correct answer for the scenario is option B. So yes, this one is also a good tricky scenario. So in the procedure inventory, we have a dilation and evacuation procedure performed with the help of vaginal suppositories. In diagnosis inventory, there is an electric termination of pregnancy and pregnancy complicated by fetal abnormality. So these are our diagnosis inventory. So let me explain you the procedure with the help of this image. So actually there are two kind of procedure. One is dilation and evacuation and one is dilation and curettage. And first let me explain what is a dilation, evacuation and curettage means. So in dilation and evacuation, there is a dilation, there will be a dilation of the cervix and surgical evacuation of the uterus after the first trimester. And this is mostly used after the first trimester of the pregnancy. So it is a method of abortion as well as common procedure that is used after the miscarriage to remove the pregnancy tissue. So that is what a dilation and evacuation means. And in dilation and curettage, it refers to the dilation of the cervix and surgical removal of the part of the lining of the uterus and or the contents of the uterus by scraping and scooping. So you can see a speculum will be placed, and with the help of a curette, the contents of the uterus or the contents of the fetus will be scraped off from the uterus. So that is a dilation and curettage. Now, is it clear, coders, the difference between two procedure, D and E and D and C? Is that clear? Great. Okay. So now that it's known, let's come back to the coding portion. So these all are our code options, and after a bit of churning here, we have 59855, which is coding for induced abortion using vaginal suppositories. We have 59856, which is for induced abortion using vaginal suppositories plus dilation and curettage and or dilation and evacuation. And we have 59840 for induced abortion using dilation and curettage, 59841 for induced abortion using dilation and evacuation. So 59856, which is for induced abortion using vaginal suppositories along with a dilation and curettage or dilation and evacuation. So at this point, I would like your attention over here, this part of the question where it's been mentioned that a speculum was attempted to be placed, but the fetus was already delivering into the vagina, which means they planned for a dilation and evacuation. But once they placed the speculum, they saw that the fetus was already delivering into the vagina, because of which they didn't perform a dilation and evacuation, right? So there was no D and E performed in this scenario. Is that clear, coders? Yes, you have to be very, very forensic. Okay, please let me know, coders. Is that clear? Or if you have any questions, you can place it in the chat. So no dilation and evacuation was performed here. So that is a reason why we always say read the entire question completely. Don't go by what they mention in the procedure header, just under the procedure header, because during a surgery procedure a lot of things can go wrong, and maybe the surgeon will have to modify the procedure. Yes, so in that case we have to read the description of the procedure and make sure it is the same procedure that was planned, the same procedure that was planned was performed as well. So here the doctor planned for a D and E, but since the fetus was already delivering into the vagina, he didn't have to perform a D and E, which is dilation and evacuation. So no dilation and evacuation performed. That means option D is incorrect. Option C 59840, which is also coding for a D and C procedure, and option A 59841, once again, which is also coding for a dilation and evacuation procedure. Both are incorrect. The correct answer is going to be option B, 59855. Induced abortion by one or more vaginal suppositories, prostaglandin with or without cervical dilation, using laminaria, including hospital admission and visits and delivery of fetus and secondaries. That is our answer. And how are you all doing, coders? Did the explanation help? Good, great aha moment. Yes, this was a good one, and I can see why you are saying there was an aha moment in this scenario. Good, great.
Thanks for tuning in, and until next time, happy coding.